It's an honor and a pleasure to introduce to you Dr. John Entwistle. He's a neurosurgeon at the Carilion Clinic in Roanoke, Virginia. He's assistant professor of neurosurgery at Virginia Tech, Carilion School of Medicine. And Dr. Entwistle is especially close to me because we were co-residents in residency, and also I was his attending for a short time. And then he went off, once he graduated from our program, went off to do a endovascular fellowship, and he's here to present to us some endovascular neurosurgery treatments. Thank you, Dr. Entwistle. Welcome.
Dr. Warren, excited to be a part of this, and hope that it's been great to hear all these different talks of growth and challenges for the Kasumi neurosurgery, and I hope I can highlight maybe some opportunities of growth. It was good to hear that they're getting some experience in endovascular. It sounds like in South Africa and some other locations. So I'm sure this is kind of in its fledgling stages there, but my talk was really meant to be somewhat introductory, but also kind of show where we're at even currently, and how we can help this population, specifically focus on cerebral aneurysms. So I'd just like to take some time and review kind of the epidemiology of cerebral aneurysms and the challenges that we face as practitioners and patients, discuss where we've come in the last 15, 20 years with recent randomized controlled trials and guiding management of these complex pathologies, and also kind of see where we're going, because even from the first time I gave a talk similar to this, it's changed significantly, just because as is kind of alluded to, this field is ever changing, and endovascular seems to be one of those fields that changes rapidly with new devices and new technologies that make treatment of these complex pathologies not as straightforward as they used to be with regard to decision making and doing what's best for the patient. And you'll kind of see what I mean by that as we move forward. But kind of a history here. What I always tell my patients, because they ask, why did I get this? Is this inherited? I say, outside of any of the risk factors, about 2 to 4% of the general population is at risk for having a brain aneurysm, and there's a slight female predominance, and we know it's a bad thing because it's a large percentage cause for spontaneous subarachnoid hemorrhages. That's really what we're looking to avoid if we encounter it. There are connective tissue disorders, and there's a number of them, but they all come back to there's some sort of breakdown in collagen or muscular layers that predispose these types of patients to aneurysms. If you have multiple first-degree relatives with aneurysms, your risk goes up. But this is just a risk stratification. This isn't talking about the incidence of subarachnoid hemorrhage, but just the presence of an aneurysm to begin with. And then we know that patients that have aneurysms will have multiple aneurysms. So your risk goes from 2 to 4% to about 15% for those patients that are noted to have a brain aneurysm. And there's a number of risk factors, not just from predisposition, but modifiable risk factors. And so when I'm sitting with a patient in clinic or even in the hospital, when we're talking about why this happened, or what can I do, doc, to prevent it from happening again? And I say my two heaviest hitters, and these are the things that are talked about in literature over and over again for aneurysm growth, aneurysm rupture, is smoking and blood pressure control. The other ones mentioned here, alcohol use and a significant amount of caffeine, obviously increase your risk, but not nearly as much as what the literature has shown for smoking and hypertension. So it's always somewhat amusing to me when I'm sitting with a patient who smokes 1 to 2 packs a day and is very concerned about the aneurysm in their head, and they ask, what can I do to prevent it from growing or rupturing? Stop smoking. That's first and foremost, if you didn't need another reason. And the response is just, no, I'm not going to do that. Okay, well, we move on and we address it as we need to. But these are the things that I tell my patients, that this is what you can do to prevent these from growing and rupturing. Because we know that when aneurysms grow, so this is outside that the risk of just finding an aneurysm for the first time, aneurysms that grow are much more likely to rupture. So all the percentages that we're going to talk about for the risk of rupture and who we decide to treat and when, based on size, location. If we see aneurysm growth over time while we're monitoring smaller aneurysms, we know that changes how we approach it. So some of the studies that we'll talk about, some of the earlier ones, especially in unruptured intracranial aneurysms, this idea of aneurysms less than 7 millimeters, we just watch because they're low risk. But if an aneurysm goes from 3 millimeters to 5 or 6 millimeters in a year, that's a different conversation. Your 5-year risk of rupture changes with growth over time. So we have to take all these things into consideration. And this is the common question, right? Oh, doc, I have this ticking time bomb in my head, and I can't deal with that. That thought of it can just go at any time, and I definitely understand that perspective, but I also kind of have to take that time to give them a little bit more perspective. And so the data that we have on unruptured intracranial aneurysms. So the original study was the International Study for Unruptured Intracranial Aneurysms, or ISUIA. It had two arms to it, and aside from going through every single detail of that study, ultimately what they came up with, they looked at the location of the aneurysm, the size of the aneurysm, and the incidence of rupture over the length of the study. And based on that ISUIA data, it estimates that we should only be seeing about 9,000 subarachnoid hemorrhages a year. But in reality, we see 2.5 to close to 3 times that amount, or 3 times that amount in a year. And we also know that the average size when aneurysms do rupture that we see is around 6 to 7 millimeters. So it's under that 7 millimeter mark. So although this data is useful, it's not hard and fast, right? It doesn't guarantee that it's a small aneurysm isn't going to rupture. And so there's just looking at the size and location really isn't enough. And so this is, and I hope you guys can kind of see that this is something that I use commonly in my clinic. This is the phases aneurysm risk score. This is a culmination of a number of studies and its own study where they looked at not just the size, location, but other factors associated with the patient. So their heritage, because we know the Finnish population and Japanese have a higher incidence of aneurysm rupture, and modifiable risk factors, right? Hypertension, the age of the patient, and then they risk stratify location, because we do know that posterior circulation aneurysms are riskier and there's a higher incidence of ACOM and PCOM ruptures compared to other locations. And you end up with a score, and this gives you your 5-year rupture risk. And so this is my bread and butter when I'm talking to the patients. So when they have this concept of ticking time bomb in their head, but their phase score is 3, putting them at low risk of aneurysm rupture, and the next that talk them off the ledge and really kind of address the anxiety in the sense of watching this over a short period of time in the year. When you're assessing a 5-year rupture, this is relatively low, and educate on signs and symptoms to monitor for. But I still understand that some patients, that anxiety is very real and sometimes debilitating. Now, on the other hand, sometimes patients come and have a very large aneurysm, and they're told by somebody else that it's not a big deal. They just watch these, and then I have to have the opposite conversation of, sometimes that's the case, but now we're assessing a significant risk of rupture, phase score of 7 and up. That monitoring this lesion is actually riskier than undergoing the risk of treatment, whatever that may be. And so these are the tools that I utilize in my clinic when I'm having these conversations. And then this is ultimately what we somewhat want to avoid, and it's the analogy I use for my patients that come in with subarachnoid hemorrhage, either with the patient itself or family member, depending on their clinical status. And I always tell them, you're taking your first step in a marathon with regard to treatment and what you have coming down the road, because the aneurysm rupture is really just that first event. Now we have to deal with all the vasospasm and the risk that's coming along with that event. And so it's a long road. They're in the hospital in the ICU for minimum of 10 days, depending on how well they're doing and whether or not we're seeing clinical signs of vasospasm or delayed ischemic neurological deficits occur. And so this is ultimately what we want to avoid, and we're trying to do our best practice, and that's what these studies were designed for. Best practice to avoid having to undergo this type of hospitalization and falling into this category, which is what happens. So we know that almost 50% will be dependent, almost 50% will have some form of disability that they didn't have beforehand, and 10 to 15 will have severe disability. And so when I see a patient come into my clinic that returns to their neurological baseline after subarachnoid hemorrhage, it is rejuvenating. It's what kind of gets me excited and really kind of rejuvenates why I'm doing what I'm doing. I wish it was more. I wish it was every single patient, but this is just the nature of this disease process. And so it's complex, but it can be rewarding. So treatment, and this is where there's still a lot of debate today in neurosurgery and neuroendovascular interventions, because we have so many things to consider. First and foremost is when we're considering open versus endovascular treatment of aneurysms, it's not just as simple as the aneurysm's location. It's can we get there from an endovascular standpoint? Do we need to have other treatments involved? So antiplatelet therapy for a possible stent. What's their comorbidities? Can they undergo surgery? Can they undergo general anesthesia? And in a few patients with these large aneurysms, is it causing a neurological deficit where surgical intervention is necessary? But these are all things that we have to consider very quickly in the subarachnoid population. And we have time to kind of have these conversations with patients in the outpatient setting. And this is the classic debate here is treatment modality. So we're talking about craniotomy and open surgery for microsurgical clipping of an aneurysm, which is depicted on the left here. And then my training encountered both of these. And then there's the endovascular, which is where we're going through. In this picture, it depicts transfemoral access to access those aneurysms from inside and place coils or other devices that we'll get into. But like I said, even since I made this talk initially back in fellowship, 95% of my training was transfemoral. And then, literature continues to come out to support different types of access. And so we know that transradial, which is now about 95% of my practice, transradial access for treatment of vascular diseases. And so this is early ambulation. We have lower risk of groin complications. This is a patient who, goes under anesthesia, has their treatment of the aneurysm. They wake up with a little wristband on their wrist and walking around, an hour later. And so this is kind of transitioned my practice even to the transradial access. So even, like I said, even in the short time of the last 5 to 6 years, I've transitioned from 95% of my training being transfemoral to now transradial. But there's a lot of things to consider with that as well. And so the comes what and how do we treat? And that's really where the challenge begins in endovascular neurosurgery, because what you see here is a smattering of devices that have come out in the last 10 to 15 years to treat these aneurysms, specifically in the endovascular way. Surgery has been surgery. It's been around a long time, and we'll get to where it still has a role. But each year we're having new things come out that treat these aneurysms in a what patients consider a minimally invasive way, and do a good job. And so we'll kind of touch on those as we move forward. But again, it's not perfect. Endovascular therapy, and this is what I quote to patients, about 20% will have some sort of recurrence over their lifetime. The large majority of those occur in the first 6 months. And this initial data, 50% recurrence requiring treatment, is actually high. This has gone down with newer devices. This came out of the BRAT trial, which we'll get to, which is now greater than about 15 years old, 15 to 20 years old now. But even if we do have a recurrence from an endovascular standpoint, we know that the risk of that rupturing is minuscule, extremely low. In all the trials that they looked at this were under 1%. And even in the most recent data coming from the Barrow ruptured aneurysm trial or BRAT trial, they only had 2 occur in 10 years. One was at the treatment site, one was at a remote site. And so it's kind of hung their hat on that data as far as risk of bleeding after treatment. So what we know between the two, so the initial study was the international subarachnoid trial, and then there was the BRAT trial. Kind of similar trials, but not without controversy. So ISAT had a large exclusion rate, so they're extremely selective. They waited a little bit longer before patients went to surgery, but they showed that surgery didn't have any incidence of rupture, and the ruptures that did occur in endovascular was extremely low in the delayed data. Brad didn't have as many people show up for their didn't have as strong a follow-up in the 10 years. But again, like I said, they talked about those 2 ruptures and none in the clipping group. So they still hold that clipping. Again, this is for anterior circulation aneurysms. Is more definitive and less likely to cause crossover is what we see in their data. In the early data, they showed that first year there was a higher incidence of poor surgical outcomes, and this is where the ISAT trial really kind of hung its hat. That those that underwent endovascular did not have as worse an outcome compared to the endovascular or compared to the surgical arm. And so, but what Brad showed over the time is that after that year, and by the time their 3 and 6 year data came out, that was negated. It was patients had returned to their baseline, but that first year couldn't really be ignored. And some of the older data that we look at, the effectiveness of treatment of these aneurysms comparing coiling to clipping, we're seeing statistical significance in long-term care, ischemic complications, and post-op neuro complications. So again, we're trying to use all this data to just come up with the best approach to the patient, the best approach to the aneurysm. And again, this was their takeaway, that had long-term occlusion rates. So, at 10 years, none of them had to be, no episodes of bleeding, very few retreatments. And that risk of bleeding was higher in the coiling group, with two bleeds at 10 years, one of which was at a different site. So, but really what we need to take away is that this is a snapshot in time. As I alluded to in the beginning of this talk, this is an ever-changing field. And this study is 15 to 20 years old. So it's really a snapshot in time. And I'd be remiss if I didn't talk about what's even occurred since then. So this is an example of a new device. It's called the WEB, the woven endobridge, that takes the technology of a flow diverter or pipeline, surpass, thread, whatever other device you want to talk about. And this is the first that used intrasaccular. So instead of placing coils, you place this device in the aneurysm and it shuts it down similar to a flow diverter would, but it's within the aneurysm itself. So this can be used in ruptured cases because we don't need antiplatelets, which we try and avoid using in subarachnoid hemorrhages. But this is one of the newer iterations that's completed its trial, that has these results, which we describe as adequate occlusion of the aneurysm without significant recurrence or bleeding. And so this is a newer device that's really pushing the challenge on the surgical arm, because this is designed for wide neck bifurcation aneurysms that have classically been quick to go to surgery. So whether that's MCA aneurysms or ACOMs in younger patients, this is specifically designed for those aneurysms. And what they show here is complete occlusion, which is, if you think about the pathophysiology of a aneurysm formation, injury to that vessel wall. And so what they're showing here is the device in, you have complete occlusion, and then this is what they kind of describe this as it's not truly a neck remnant because the edge of the wall has epithelialized, but it creates a bump depending on how the device is placed inside the aneurysm. This shows an analogy of a small neck remnant that still occurs, that's monitored, and then this is considered aneurysm failure. But adequate occlusion was achieved in over 80%, and small amount of retreatment. So we're seeing these retreatments go down. We're getting high amounts of occlusion. And again, this is through a transradial or transfemoral approach. And then again, later on after that study came out, they looked at specific to ruptured aneurysms, because unlike coils, you don't get this immediate picture of the aneurysm no longer filling. This occurs over time, usually in the 6-month mark, where we take further pictures, but so that rebleeding rate was 0%. And so it continues to kind of push that envelope of endovascular treatment. So my whole point is, you can't look at these things through a tunnel. It can't be, I have one tool in my toolbox and that's the only thing I'm going to use. You have to really look at these from a comprehensive standpoint, and I have some cases to kind of depict that. So this was in my first year out, which is now about 3 years ago, a 74-year-old male who had Parkinsonism. He had an ACOM aneurysm that was noted on encephalopathy workup. He has high blood pressure, kidney disease, Parkinson's. And so this gentleman to undergo any sort of surgical intervention wasn't reasonable, but although he was dependent to get around, he was cognitively intact and did elect to have treatment. So this is an angiogram. We see the aneurysm here, large aneurysm. So his PHASA score was high for, rupture in the next 5 years. And the discussion was, how can we treat this? We have 2 A2s coming off with a wider neck and a patient who wouldn't tolerate surgery. And so the prep was possibly attempting primary coils. There's a balloon here out in the A2. And during coil placement, I was not happy with how much we saw on the AP and the lateral. This coil kind of encroaching on this ACOM complex. So he was prepped for a possible stent in hopes to be able to take it off, but we placed a stent through that device. So there's the stent tines from A2 to A1, protecting those parent vessels. And so this is a side view. You see down the channel of where the A2s take off. And so that's patent and treated that aneurysm. And he was discharged on post-op day 1, didn't have any creat issues and no evidence on follow-up angiograms or MRAs. But I show that case to basically kind of come into this case, which was again, this is 3 years ago now. And this is a gentleman that was initially went to the ER for a trauma, and they read his CT as negative. And then a month later, they read it as a possible aneurysm, which you can see here, this hyperdensity in the interhemispheric region. And he was notified a month later after that. So he showed up to the ER all excited and upset about it, although there was no bleed. But we did an angiogram on him, and he had this large ACOM with multiple ACAs. And I think I'm showing, yeah. So this is the A1 coming in. You have multiple ACAs coming out as wide neck ACOM aneurysm. And this is a down the channel view, so side view, large aneurysm. And so, treatment considerations for this would be, surgical clipping. Stent, I think, would be challenging. It's hard to make this turn, and this is probably the ACOM or the ACA that we would want to protect and get a narrow neck. And so, kind of similar to that older gentleman. And so we discussed placement of a web. So this is a large microcatheter inside the aneurysm. Because this is a large aneurysm, we have to push a large device. And so what the video will show here is afterwards the web is inside the aneurysm here. And you'll see, down the channel view of that right here where the web is not, which is the A2s coming off. So this was about a 30 to 40 minute procedure where we placed that device, and he's set to follow up here months. I just treated that a couple of weeks ago. So if I had this device 3 years ago with that older gentleman, this definitely would have been my first choice. 37-year-old with headaches. We see subarachnoid here. Aside from being combative, he was high tobacco user. And so this was his aneurysm coming off the PCOM. Looks like a jalapeno to me. 37-year-old anterior circulation. This, by Bratt trials, they would say a surgical clip. It's had a very narrow neck, so I felt like an endovascular treatment was reasonable. And we got a good occlusion here. He got through his subarachnoid and went home, and on follow-up, doesn't demonstrate any recurrence. This little neck remnant had gone, and the PCOM remained patent. But it's not perfect. And so it's, again, narrow neck, small aneurysm along the PCOM, who is a subarachnoid hemorrhage. And we had a great occlusion at the time of treatment. And you see, if you imagine a line here, this is the neck of that aneurysm, and this looks adequate. Very happy with that result. On follow-up angiogram, we have coil compaction and aneurysm formation. This is 3-dimensional angiography showing that aneurysm recurrence. And so I'm not one to just continue doing the same thing over and over again. And so she went for a surgical clip where we occluded the aneurysm. This is a CT that just shows that coil just gave you that perfect spot for the surgical clip to go, and didn't demonstrate any evidence of recurrence. When my residents are asking, how do you decide? I say, when we're in the angiogram suite and we're seeing aneurysms, sometimes we can't predict how the coils are going to sit. This is an MCA aneurysm with a Murphy's teat down here, likely the rupture site from that subarachnoid hemorrhage. and wide neck, but I say, it's wide enough, but if we get coils to sit down there that keep these MCAs patent, it's worth a shot. So, we go in, take this wire, place it in the aneurysm, but the long and short of it was it didn't. It did not sit inside the aneurysm. It continued to encroach on these MCA vessels. And so this patient goes for surgical clipping. It's a lower risk and a low time frame to go from here to here, and see if we can get this occluded, avoiding a craniotomy if possible in a high functioning patient. But ultimately, this needs to be treated. So the patient went for surgical clipping, and it's kind of showing the end result there. Going back to my initial discussion of outpatients, so this was a lady incidentally noted to have it's really an M2 bifurcation aneurysm. It's a little distal to the MCA bifurcation here, but it's small. It was 4 to 5 millimeters, really not that abnormal of a shape. And I tried to, talk to her about observation, because for me, this is a lower risk aneurysm, probably 1.3% risk in 5 years. But she was not having it. She was, this is a bomb, you need to get it out of my head. I'm going somewhere to get it treated. And so, I'm happy to oblige. So the question becomes, well, how do we treat this? Stent possible, probably, maybe. It's a little odd shape for a web. And so really this is, for me, is another surgical clip. And so she underwent surgical clipping. This is a follow-up CTA, shows where the clip is. And this is an angiogram that shows that the complete occlusion. So normally I wouldn't have treated this, but the patient had basically requested, and really I couldn't, my conversation and to try and keep her calm wasn't enough. It's another example of a difficult case. 57-year-old female with baseline paraplegia came in with subarachnoid hemorrhage and had this basically blister type aneurysm along the basilar apex. I was on vacation, and my partner called and said, I don't think this lady would tolerate a craniotomy, and it's also a pretty low riding basilar apex. And so one of the devices that we have, so this is a time where, placing a coil in here alone just is not going to work. And so having a stent in place is necessary. Well, there's a stent called the Pulse Rider, a very small amount of metal profile. So in this patient, it's a subarachnoid hemorrhage that you're trying to avoid putting on dual antiplatelets. Having a device that may be able to tolerate a single antiplatelet alone is worth it. And so we place this device. You can see the tines, one here, and then into the basilar artery, and the coil placement afterwards. And so we're able to get complete occlusion of the aneurysm on follow-up angiogram. And she did not have any bleeding complications secondary to her aspirin and Plavix. And then finally, and this is just to show, again, that these devices that are coming out are just doing really well. I actually just treated this yesterday, 64-year-old with this heart-shaped kind of a mid-range neck as far as I'm concerned. I think it was maybe possible in this one, but there was an acute turn in the A2 here. I prepped her for a possible stent. I kind of prepped her for everything, primary, balloon, and web, and that web device, and thinking that the web, the way it's shaped, would kind of sit at the top of it here and come down. And upon placement, so this is our catheter. I would have liked my catheter here. It wanted to go here. And then upon placement, this device basically took you can see it here, takes the shape of the aneurysm. There's the tines of the device here, herniating into the heart here, and then a very small herniation at the detachment zone into the A1. So this was treated with, I sent her home on aspirin. She was discharged this morning. And so pretty impressive device to just be able to take the shape of that, and we'll see how that angiogram looks in 6 months. So bottom line is, as new devices come out, further randomized controlled trials are needed, but this is some great tools to treat a very complex pathology, and it seems to be changing even the short time that I've been attending in it. Thank you. Any questions?
Very good, Jay. Thank you very much. That's an excellent presentation. Regarding clipping versus coiling, if you're starting a new program and you need to take on aneurysms and treat them in the best way you can with limited resources. Do you think clipping is still the standard for that, or do you feel like because patients do so well with coiling, because the postoperative care isn't as high maintenance, that the upfront costs of, say, starting an endovascular program would save costs in the long run? Or do you still think clipping should be the standard in any starting program? Or is this the new baseline?
Yeah, it's I would hate to call it a standard just because I think there's so many factors involved that you're touching on. So the resources available, if the resources are available, then I do believe that an endovascular would be reasonable to be a standard. Now, if not, if those are not as easily available, and you know, there's a lot of resources that are needed for endovascular therapy. But if those aren't available, then I do think clipping, you know, as the study has shown, it's more definitive. So even getting access to an angiogram suite to follow these or MRIs, you know, clipping definitely ends up being more definitive. So I think if the resources are not as easily accessible for an endovascular treatment, then surgical clipping would remain a higher volume compared to endovascular treatment.
Very good. These treatments, go ahead, Dr. Awar. I was going to say, are being regionalized here even. We're saying that there are certain centers where aneurysms will be treated. We transfer out of grant to other hospitals in our community for aneurysm treatment. In Kenya, I'd be interested to know from Dr. Olunya or Dr. Aguthu, are aneurysms being treated at every center that's doing neurosurgery, or are they all being sent to one center in the region?
If I may, they're being treated in Nairobi and Eldoret. In Nairobi, the patients have two options because at Aga Khan Hospital in Nairobi, they are able to do endovascular coiling of the aneurysms. However, in the other centers, we typically have the aneurysms clipped. And hopefully that we can progress. The usual problem with the endovascular coiling has been a cost implication. And of course, the number of practitioners who have that expertise are still limited to the larger centers in Nairobi. And perhaps Dr. Lunya can comment further on that.
Thank you very much, Lee. I think just to follow on what you said, we grew up clipping aneurysms. Now, if somebody comes to my practice, I actually offer it to the person who does the coiling first. And we look after the patient together. If it is something that needs clipping, then we clip it together. When I tell them, quite honestly, in what I know of the disease process, they will do better with that route, and I'm big and bad enough to say so. The only difficulty with that is there's going to be de-skilling, because for the younger neurosurgeons, therefore, it'll be more difficult for them to get the practice in terms of getting the clipping done. But thus far, since there's so few people who are actually, so few centers where this coiling is actually being done, in our region, we actually got 2 people only who do the coiling thus far. So as time goes on, I think there are some of the younger neurosurgeons who are interested in this in terms of fellowship and so on. So I think that situation will change. But currently, most of us do the clipping.
Great. I know, Dr. Entwistle was supposed to come with us to Kisumu in 2020. Unfortunately, that trip had to be canceled due to COVID, but it will be interesting to have you there so you can assess the situation and see what could we do. You know, we've got to think ahead with this stuff. And again, we want Kisumu to be a premier place where people can have access to all these things. So I would really love to get you to Kenya so we can start thinking about how we can advance neuroendovascular surgery there and such. So great.
Great presentation. And one last question regarding coiling. Dr. Olunya, you said you will send patients for coiling if possible. Who's doing it there? Is it interventional radiology? Are these radiology trained physicians, or are they neurosurgery trained or neurologists?
The ones that are doing it in Nairobi are neurosurgeons.
Neurosurgeons.
When we started off, of course, it was interventional radiologists. And I think the first doubly trained in the UK at the time, was when the neurosurgeon said he was going to do the coiling, it was kind of strange. But now it's common practice for our trainees to do both.
okay.
Yeah, so it's a neurosurgeon who does it. Yes.
Thank you.
Now, how many neurosurgeons in the country are endovascular trained? Just to give us a perspective.
2. But I think they're supposed to be, I'll say 2.5. One doesn't do it as much. But the 2 that are in vascular trained, there is one is currently out of the country doing some work out in Namibia, but there are 2.